Hello, I'm Dr. John Kruse, and welcome to today's question and answer hour, where I will try to answer questions based on the videos that I released this past week and on other ADHD topics and mental health more broadly. As usual, the comments here are intended for general information, not specific treatment recommendations. And in addition to a short review of the two videos, one which is a new video, one which was a sound edited release. There were some leftover questions from last session, which I'll get to first, even though I see a bunch piling up already. So the two videos released last week were the new one was on narcolepsy and ADHD, and narcolepsy, which is characterized by excessive daytime sleepiness. So people literally fall into complete sleep, not just feeling drowsy or tired, often sort of at the drop of the hat or with little provocation. Also have nighttime sleep architecture is measurably abnormal, particularly with REM sleep intruding early on at the beginning of sleep. And since Max likes me to say it, other symptoms like hypnopompic and hypnagogic hallucinations. So hypnagogic are when dreamlike states are intruding just as you're going to sleep, but you're still awake and as a hallucinatory experience. Hypnopompic are ones that wake you from sleep. Anyway, excessive daytime sleepiness and sleep disturbances are also common in ADHD. Having one of these conditions makes you more at risk for having the other, and they can be confused for each other. I mean, there are clearly symptoms outside of sleepiness and that characterize ADHD. And there have been several genetic studies. Clearly, there are multiple genes in common. And one concern or issue is whether narcolepsy causes people to develop ADHD or whether ADHD causes people to develop narcolepsy. And using a technique called Mendelian randomization, um, it seems pretty clear that it's not a cause and effect either direction. It's more a compounding effect that there are genes for dopamine metabolism, glial activity, iron metabolism, and autoimmune genes that increase the risk for both of those conditions. So the other talk was on hypersmell. So it's often anecdotally reported by people with ADHD that they are more sensitive to smells than other people. And there have been a few studies in children using quantifiable it's not quantifiable smell sensitivity measures. And at least in some of these studies, children with ADHD were more likely to be hyper smellers, more acutely detecting odors, and less extensive and less consistent data about that in adults. And whether that's a curse or a blessing, I'd say read some of the comments on the videos there. It can be either or both. So the questions left over from last time. So I'll start with a shout out to James Alexander. So he had a question in my video on EPA, fish oil, and ADHD, which the majority of studies indicate can be helpful. I had talked about in terms of what preparation or what ratios you should use. I incorrectly and inaccurately was using the data from 30 plus years ago, which was very rudimentary, which indicated that in many fish species and other species, there was a 2-to-1 ratio of EPA to DHA. And since that was found in nature, that's probably what we should mimic. So the bigger picture is we've much more extensively looked at DHA and EPA. So those are both omega-3 fatty acids. And not only is there substantial variation in species to species, there's variation in different species. So bears at different times of the year, depending on how much fish they're eating, have different EPA to DHA ratios. And it depends also which tissue you're looking at. So the brain, particularly brain cell membranes, have more DHA than in many other cell membranes. So if you're looking at red blood cells circulating in the blood, if you're looking at brain tissue, if you're looking at serum levels, you're going to get different ratios. So I would still maintain that the overall message I delivered, that to me it makes more sense to take a combination of EPA and DHA rather than a EPA purified um, concoction. And there are purveyors out there who are selling pure EPAs and touting that that's the best source. Um, so thank you to James Alexander for pointing out and correcting that. I did thank you in the, so I've appended a note for now to that video, and I thanked you by your initials. If you want me to thank you by your full name, I'm happy to do that. Two other questions left over from last time. Blue Bassett um, had a question about whether ADHD, and I'm not remembering how they framed it, whether it increased cognitive decline or led to resistance of cognitive decline. And there have been a few studies suggesting rates of dementia are higher among those with ADHD. One study, which I've criticized at length here in different videos, by Levine et al., it was an Israeli study, looked at people who were only diagnosed with ADHD in their 50s or older. So these are people who explicitly did not have childhood ADHD. And they found, I think, threefold higher rates of developing dementia in the next decade. Still, the vast majority of individuals, even in their 60s or early 70s, were not demented in this group, but it was a substantially higher rate. But my interpretation of their study is that they were just detecting early manifestations of dementia rather, and so it was a cause of reverse causation, that dementia can look like ADHD, but if you had no previous history of ADHD, that is not a good indicator of, again, what childhood ADHD. So there have been other studies, though, that suggest an increased risk, maybe particularly with Lewy body dementia, where there's dopaminergic cell involvement is the strongest case. What's really hard to sort out is that there are a variety of confounding variables. So we know individuals with ADHD are much more likely to have sleep problems, much more likely to have depression, much more likely to have lower socioeconomic status, lower educational attainment, all of which themselves are independently associated with rates of dementia, and other things where ADHD may have a indirect role by ADHD disposes people to head trauma. Head trauma itself is a risk factor for dementia. So on the other side of the coin, there's at least one study looking at anatomic connections, and well, there have been multiple studies showing that for certain tasks, people with ADHD are activating more of their brain. And the thinking from that is that that could be helping with cognitive reserve and greater preservation of more areas of the brain being more actively engaged throughout someone's life. So that may have a protective effect. And I would say, in my opinion, these two schools have not been reconciled. So, if you Google it, it'll say ADHD causes dementia or is associated with higher rates of dementia. Again, I'm not convinced that we can say that yet. And then the third question, I don't know if there was a question, but, and I'm forgetting who identified a recent paper about growth hormone circuits and feedback um, in terms of growth hormone and sleep wake cycles. And I'm not sure of any direct ADHD studies or correlations that would add to that. So I've, I've located the article. I haven't read it in depth yet. So that's jumping into the questions now, and I hope sound is good. It looks like it's still on. So James Alexander, hello and thank you, has asked a question about some doctors claim that taking vitamin D supplements increases your risk for hypercalcemia and arterial calcification, and that these supplements also need to include vitamin K2 to minimize this. and calcification risk. And many supplements are now including vitamin K2 with the vitamin D. And he wants to know what I know of the data supporting those claims. And I can give a really quick and simple answer is I don't know enough to comment intelligently. I mean, it sounds plausible, but I don't know how clear cut and robust the risk really is, or if it is just a statistical artifact. So sorry. Um, so hello, Dennis asks, is it true that um, TMS, transcranial magnetic stimulation, R's for repetitive, is the next frontier in autism treatment? Um, so, as Yogi Berra and others have said, prediction is really hard, especially when it's about the future. So, the next frontier in autism treatment will be whatever works and is effective, because by and large, although, for example, if someone has ADHD symptoms in conjunction with an autism ADHD spectrum diagnosis, the stimulants or other ADHD medications seem to work at those targeted ADHD symptoms, but not at the core autism um, symptoms. So, right now, I can say we don't have much that's very effective at the core symptoms of autism. And the next frontier is going to be whatever really works. It's not going to be depriving people of vaccines, I can tell you that. Um, So I do not know how strong or robust preliminary findings so far on TMS have been in autism. So I'm guessing that who's ever touting this is the next frontier is seeing enough evidence that they think that this will be overwhelmingly helpful. And it just makes me, it may well be. And it's also possible that most of TMS is looking at what structures specifically to target in the brain. And just as the study by Gao on neurofeedback and EEG, neurofeedback found that targeting the whole brain's pattern of activity was more effective than targeting a specific single network or system. That, and again, TMS is usually a focused approach, so it may be that an approach that targets the whole brain pattern of activity is going to be more helpful than something targeting any specific symptom network underlying any symptom. So that's what I so that's all speculation. So I will stop there. So James Alexander, I'm guessing this is new topic and not the vitamin D. Organic acids like citric acid and amino acids like glycine are used as chelating agents in chelated mineral supplements used by ADHD patients for help with symptoms such as magnesium citrate, zinc oxide, and potassium glycinate. When you ingest these chelated mineral supplements, do the chelating agents react with the water and other substances inside you to reform the chelating agents? For example, does 400 milligrams magnesium citrate form 400 milligrams of citric acid? And can you get similar negative side effects from ingesting these chelated mineral supplements as you would from ingesting the chelating agents themselves? So, again, I'm going to largely pass because I just don't know what the actual data may show or not. Um, and I'd say most of these organic acids, to my knowledge, are moderately weak chelating agents and not extremely potent ones. So, yeah, so my guess is that their effects are going to be only partial anyway, but I'll stop because I just can't say anything intelligent there. So Rickroll asks, what do I think of natural supplements for ADHD like L-tyrosine, acetylcholine, alpha-GPC, phosphatidylserine, Alcar, saffron, etc. Um, so none of these yet do I have a specific video on. I do have on some other supplements like N-acetylcysteine, NAC, magnesium, fish oil. So I'd say with almost all these supplements, we're in a what I would call just a gray area. So many of these supplements have evidence that they may affect either neurotransmitters or they may affect um, oxidative stress, or they may affect mitochondrial function, or they may affect autoimmune, dampening down inflammation in ways that we think should be positive for helping with ADHD. So there's some basic brain science that suggests they may be helpful, and most of them have extremely little research in actual clinical populations. So saffron, I think there are just two studies, one at least from Iran, um, moderately small group size. Um, so it's certainly possible that many of these things have real and robust effects, but I would say none of them have reached the level where we've adequately demonstrated it, and it's reasonable to say, yeah, go ahead and try it. On the other hand, most of these are have not been shown to have many or common toxic effects, so it is probably safe to experiment. And specifically regarding the L-tyrosine, which is a precursor to making dopamine and norepinephrine, I will sort of refer or summarize the video, and I'm not sure what I called it, about diet and the likelihood it's really going to affect neurotransmitter levels. And yes, you can do exquisitely complicated taking selective amino acids to increase the likelihood of branched chain amino acids getting into your brain. I mean, so one, even if you're taking it, it could get chewed up and digested. It could be absorbed poorly. It may not get through the blood brain barrier in the amounts you think it's going to be. And the most important thing is if a shortage of L tyrosine is not what's the rate determining step in making more dopamine in your brain, then flooding in more L tyrosine, even though it's, yes, it's an essential component. Yes, you need it to make it. But if that's not where the shortage is occurring, then shoving more in is not going to increase synthesis. And the analogy others came up with, but I like because it's useful, is if you are in a automobile factory and say you're trying to make more Teslas, get more Teslas off the um, not conveyor belt, the supply line, and you say, well, I have a whole bunch of right passenger side doors. That's an essential component. Each car absolutely needs one. So I'm going to shove a whole bunch of these precursors, these passenger side front doors into the assembly line. If that's not what's limiting what's making the speed with which you get Teslas completed off the assembly line, all you've done is added to a pile up of right passenger doors on the assembly line. You haven't created more going off the end of the assembly line because it wasn't a shortage of that led to it. So I don't know that we have good evidence that a shortage of L-tyrosine is responsible for too many individuals' lack of dopamine, whether or not the separate issue is they're lacking dopamine. So, so again, so the summary with the natural supplements, some of them may be really helpful. I also have talked about lion's mane. I've talked about methylene blue. Um, my guess is some of these will turn out to be effective and some of them won't be, and we don't know yet. So Flowers asks, is Bibi Netanyahu a psychopath? Please explain. So my interpretation, and I will say I'm not going to give a factual diagnosis. So psychopaths display reckless regard for human lives and manipulation of others for their own gain and don't show much um, physiologic, normal emotional response to these situations and maybe differential activation in parts of the brain. My interpretation is that the way Netanyahu has conducted a war which has killed well over 60,000 human beings. I mean, I think part of it is that he and many others in a wartime situation characterize their enemies as inhumane, that they're all cruel, sadistic murderers, that they're lowly scum, that they are subhuman, which makes it easier to justify killing them. I would also think that there is nothing in the way he has conducted a war, to me, increases Israel's long term stability. Does it increase its short term stability or safety? Absolutely. But I think for every individual you've killed and for every one of the 2 million homes you've destroyed, you are likely to have in, you're likely to have caused more than 60,000 new people who are really, really pissed off at you for, I'd say, completely understandable reasons that you've killed their relatives and you've destroyed their homes and any chance of them to make a living. How that augments or supports long term peace or stability, I have not seen any even remotely convincing case for that. So I think the pundits who speculate that his major preoccupation for continuing a war, I mean, I think he probably does believe that some aspects of it increase Israel's security. Again, his negligence that led to the conditions where Hamas could attack at such an extensive level to begin with, I think reflect that military security, even though that's what he's based his career on, has not really been a priority for him. That much of this, it's hard for me not to see that how he has conducted this war is, at least in large part, intended to be a delaying and distracting strategy so that his own political life is preserved as he faces massive, well documented corruption charges. Maybe I should stop right there because people don't want me to go into politics. So, um, but actually, I will say one more thing because it's been so prevalent, even among the mainstream news, giving Donald Trump credit for resolving the war in between Israel and Hamas. I'd say one, even though we have a ceasefire, at least during several weeks early in the ceasefire, the rate at which Israel was continuing to kill Palestinians was not much different than the overall rate of the last 2 years. So, whether this is a real ceasefire or not, time will tell. Two, Trump's role in ending this war was saying from in January, this is a bad war. The war should stop. In February, this is a bad war. The war should stop. Actually, he was saying before January, I will stop the war the first day, week, month I'm in there. February, March, April, May, June, July, August, September, October, he was saying the same thing. The war is bad, stop the war. I should say at the same time, every one of those months, he was also saying, Israel, go ahead and do whatever you want and you need to do to take care of this. He didn't start saying anything differently in October. I don't see he having any direct role whatsoever in stopping the war. Um, are many Israelis, including Netanyahu, giving him credit? Yes, but they have learned that flattering Trump is a way to be on his good side, and it makes sense to be on his good side unless you want to be on his bad side, where he's also shown he is extremely petty and vindictive and violent. Um, so I really object to giving, I mean, if you watch the movie The Apprentice, not the show, one of the three life rules that if you look at Trump, everything he does is attack, 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 deny, 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 and take credit regardless of declare success, regardless of what actually happened. That's what we see him doing here, taking credit, declaring success when he had, I mean, I think hostilities, if they have decreased or are about to end, are entirely, I mean, it wasn't Hamas that said, let's change course. It was Netanyahu, and he changed course because he had killed and destroyed most of the targets he could kill and destroy. And he saw that if he could finally get some of the hostages out, which clearly had absolutely not been a priority in any of his negotiations or actions in the 2 years prior, that it did work for a short term political benefit. Anyway, I will stop. I know this is turning people off. So Max, hi, mentioned that an individual who has parents with ADHD could influence what treatment options you may consider for a patient. Could you develop on that? Um, I'm not remembering what context I was saying that in, but I'd say, I mean, particularly, I'm not sure it would redirect or change medication, except to the extent of trying to implement systems to help the individual to be, I mean, particularly if it's an adolescent or young adult who's still living at home and maybe relying on their parents, but the parents themselves are less likely to be reliable or consistent because of their own ADHD. So it might be more strenuously trying to set up reminder systems, protocols, ways for them to remember their own medication. But I think the bigger thrust of it would be in the CBT and other psychotherapeutic approaches to one, helping them understand that other households or other partners or people in life or other school systems may operate differently than the varying structure they may have been exposed to. Um, Often helping parents understand their own ADHD, and that can help them change their own behavior for their own benefit and hopefully the benefit of other people in the household. I mean, certainly there's research suggesting with ADHD and a multitude of other conditions that expressed anger and other unregulated emotion tends to worsen the severity of mental health conditions, and finding ways to redirect, come up with other emotions, come up with non emotional responses to situations can have a beneficial effect on outcomes and severity. So I hope that address that. Sorry, I've scrolled too far and I saw Rick Roll, I think, had a. So Rick Roll asks, does bupropion, Wellbutrin, increase anxiety? It seems to be a general consensus that it does and it can, yet the actual literature suggests that it doesn't increase any anxiety any more than SSRIs do or can. What do you think? So to begin with, about a quarter of people starting out. So one of the advantages of the SSRIs when they came on the market in the 90s, lots of people think that they were more effective than the tricyclics or the MAO inhibitors, which were the standard antidepressants before them. Success rates are comparable, efficacy sizes are comparable. Part of the attractiveness of SSRIs was most people could tolerate a therapeutic dose to begin with, which is extremely unlikely with tricyclics. People need to start at a low dose and build up slowly. So they were much easier for a general practitioner. They were easier for anyone, but particularly a general practitioner who treat more than 3/4 of cases of depression. Um, so it's standard doses, SSRIs, the treatment doses. About a quarter of people have some amount of agitation, increase in anxiety, even though these are drugs that measurably decrease anxiety in the same time frame, 2, 3, 4 weeks in, that they decrease depression. Um, Wellbutrin has much less evidence that is effective in treating any generalized anxiety, panic attack disorder. So, to that extent, it's less helpful. So, I think that some of the symptoms that are tracked and classified as, I think initial anxiety and SSRIs and bupropion are roughly in the same ballpark. But one, they are much more likely to persist with bupropion. They certainly can go away, but they are more likely to persist because it's activating norepinephrine and dopamine and not directly activating serotonin systems. Um, are there so there's many of my colleagues, if someone has anxiety or an anxious depression, they will not even consider bupropion. And I think I talk about this in my bupropion Wellbutrin video. One of the patients I worked with during residency was a man in his 70s, chronic depression for years, and literally shaking, vibrating. He was so anxious and agitated in his depression. And they had tried other agents and started him on Wellbutrin just as I started working with him. And within 2 weeks, depression was gone completely and no tremor, no anxiety. So for that individual, his anxiety symptoms were apparently all a manifestation of his depression, are completely treated by this Wellbutrin. So yes, absolutely, bupropion can increase anxiety. So more directly in the setting of ADHD, many people with ADHD, their anxiety is a byproduct or exacerbation or worsened by their ADHD. So if you are making mistakes because you're inattentive and you're missing your details or dropping details, and you know that you do that, you may be constantly vigilant. You may be worried, did I forget this? Am I, or you may be worried about, did I blurt something out or did I forget to say something to somebody? So if you are adequately treating ADHD, very often, even with a full-blown stimulant, which can increase anxiety, these medications in the setting of ADHD can decrease anxiety. So it's a complicated situation, and I hope I explained most of the main options or variables adequately. But if not, call me back to it. James Alexander points out that many of the supplements recommended for ADHD contain large amounts of antioxidants. For example, practically all omega 3 fish oil supplements contain high antioxidant ingredients like rosemary extract, um, prevent oxidation in the fish oil, and EPA, DHA themselves are strong antioxidants themselves. Despite antioxidants reducing the chance of cancer cells forming in the first place, some researchers and radiation therapy for cancer patients in the National Cancer Institute selenium and vitamin E cancer prevention trial found that supplementing vitamin E increased patients' risk for prostate cancer. Do you think there are health risks from daily consumption of high levels of antioxidants from supplements? Um, so, I mean, what's difficult there is that vitamin E, other than being, has other actions than being an antioxidant, and selenium also had other actions on the body other than being an antioxidant. So whether it's toxicity rather than beneficial effects in the studies is due to its antioxidant action, I'd say we have very weak evidence for. Um, so it brings up that with any of our supplements, they are usually delivering a range of substances and contamination and other things are present. So it's really tricky when we try to pull out just one aspect like their antioxidant properties. I mean, EPA, so omega-3 fatty acids, yes, have antioxidant properties. Yes, they have direct effects on membrane mobility. So a large amount of, so with EPA, DHA, and versus omega-6, this is one of the few cases where you are what you eat. A lot of the omega-3 or 6s get incorporated into cell membranes, and there are good studies looking at flexibility of membranes and the performance of receptors, serotonin receptors, and others in those membrane walls. So, having a different, higher rate of DHA, particularly the omega-6s, can change how your neurotransmitters are interacting with cells. And we know with the fish oils that some of what a big chunk of what happens to them is they get converted into prostaglandins, and prostaglandins are signaling sort of hormonal like molecules, but the omega-3s tend to regulate the immune system, whereas omega-6s, which are rich in the seed oils, which are a prime target of RFK and others right now, omega-6s tend to be produce prostaglandins that are pro-inflammatory and increase autoimmune or increase activity of cytokines associated with destructive inflammatory processes. So many of these things are having multiple actions, and how many of them are tied to just their antioxidant effect? I don't know good data to clarify that. Um, so thanks. Max provided the link for video on boosting neurotransmitters. And I think it's Max. So how do I approach nihilism in a clinical setting? Do you always consider those thoughts as symptoms, or do you think one can reason themselves there and still have a healthy mental health? So nihilism, from Latin nihil, nothing, is sort of the none of this matters, nothing's going to help, nothing is going to come of any good. So one of the clinical insights I got from psychotherapy training is that if anyone's showing up at your door seeking treatment, even if they are extremely hostile, even if they're extremely negative, even if they're extremely skeptical, their action is speaking that at some level, even if they're denying it or not engaged with it or can't see it, they are seeking help. They are believing that coming here, I mean, I guess the rare exception would be someone under court mandated treatment that would have no or limited choice. But everyone else is coming in because at some level they are not completely nihilistic. So part of trying to help or connect with them would be to get in touch or intact with what part of them believes, or in what ways do they think therapy or treatment, I mean, it might just be medication treatment, might be helpful. Um, so, so can nihilism, I mean, certainly an aspect of depression is nihilism, that nothing matters, who cares, we're all going to be dead. Um, what other conditions? I think, again, getting back to sociopathy and psychopathy, I think there's an element of nihilism embedded there, that nothing matters, so their bad actions don't matter, or aren't really harming anyone, or only harming people to the extent they're letting themselves be harmed. So one of the things that stems from the depression literature is that in many scenarios, people with depression, I mean, one, are measurably more depressed, negative than non-depressed people or themselves in a non-depressed state, and two, in a variety of situations, have a more accurate perception of likelihood or odds of something turning out well or bad. There's certainly other situations where they massively over exaggerate the negative, but in others, there's some more realistic attitude to that. But just because it's more realistic doesn't mean it's, I would argue, healthy. Um, I mean, I like to believe in reality and like to believe in, so that I think there's a difference between disregarding facts and holding on to likelihood of, I mean, likelihood is always a prediction, a percentage, a assessment of it's, there's a value judgment in there beyond just the facts. So I think ignoring reality is not particularly healthy despite its prevalence, but I think holding on to some optimism, I mean, even you could argue a pessimist has some optimism, because why would they promulgate their pessimistic views unless they thought they might convince others? So maybe I've said enough there. I'm happy to go back to that if it's useful for anyone for me to propound on it. Um, so Rickroll asks, do PPIs reduce tyrosine absorption synthesis? I assume that acid suppression may reduce amino acid absorption. Would L-tyrosine supplementation potentially be a good idea for someone on PPIs? So I do have another video on acid base, and I mean, there are clearly some situations, including absorption of things like amphetamine, which, if you reduce or adjust your acidity, can affect it. But at a clinical level, most individuals don't experience a big effect. Now, with the PPI proton pump inhibitor, where you may have more extreme or dramatic changes in stomach acidity. I mean, so one thing is that more of the absorption is, most of our drugs and amino acids is occurring in the intestines rather than in the stomach itself. So changing stomach acidity will also have some impact further along, but sort of the less impact the further and further along you get. I do not know how much tyrosine absorption or synthesis is affected by PPIs. I don't know if anyone specifically looked at that. So, I mean, my approach there is, again, it's unlikely, other than the cost, to be harmful. I mean, L-tyrosine is an essential. You're already getting it in your diet, some of it. Um, it's not likely to have a detrimental effect. Um, so, if you take it and see an improvement, great. And if after you finish your bottle you haven't, then it won't. Um, so Paige is commenting that the audio is very choppy. I mean, it might be that I'm not close enough to the microphone. Excuse me. Hopefully that wasn't close to the microphone. And part of it may be that I am limited to, I'm a Starlink satellite connection in a rural part of Hawaii. That's the only internet connection available. And the bandwidth for this seems to be greater than that it is when I'm on Zoom, so that audio gets messed up more readily. James Alexander says randomized controlled trials have shown even high quality DHA fish oil supplements significantly increase HDL and especially LDL cholesterol levels in patients despite lowering triglycerides, while EPA just lowers triglycerides without increasing LDL or HDL by much. Some studies even say DHA downregulates expression of LDL receptors. Are you concerned about raising your LDL levels by taking DHA, um, mostly made up of, and do we have any ideas on why EPA and DHA individually might affect ADHD? Yeah, so it looks like you're more familiar with the basic with the studies than I am. Um, I mean, one is that although there are correlations between LDL and HDL levels and you know, cardiac health down the line, there's a pretty broad range of what is considered healthy or okay. So I don't know if any of the fluctuations you've described are actually putting people in levels that would be considered partic- particularly risky or dangerous. Um, and do we have any ideas on why EP and DHA individually might affect ADHD? I mean, I think more has been looked at and researched and speculated with depression, but again, the ability of what which fatty acids are constituting your nerve cell membranes does affect neurotransmitter receptor function, and which prostaglandins are being manufactured can affect autoimmune or inflammatory brain status. So, thank you, ultra paradoxical, for my foray into politics. And I'll stop there. Hello, Dennis again. When it comes to smell, is it true that women have olfactory receptors that detect pheromones? I mean, both genders have. Yeah, I don't know. Actually, I don't even know enough about pheromones to know whether it is olfactory system receptors or where it's other types of receptors that are primarily responsible. So I don't know how much is olfactory. I mean, some of the most classic studies showing synchronization of women's menstrual cycles when they're living together indicated that it was being able to smell or intake chemicals through the nose. Smelling someone's t-shirt could have an impact on biological rhythms and on choice of who we are friends with and who we are partners with. But I believe it's not just women. Some of those studies have been done in men. I mean, clearly not synchronizing menstrual cycles, but um, other responses to pheromones. So James Alexander said in past Q&As, I described a person, which is me, who had a parent and sibling who were very opinionated and strong in enforcing their opinions, leading that person, me, to feel it didn't really matter what the person said, it would be criticized and or ignored, and that there wasn't much value in speaking up in group situations. That person's mother having a strong antipathy towards taking medicines or supplements. Did you ever observe any of the core Asperger's autism traits in either this person's parent or sibling? I've had three friends who described their family in virtually identical terms. And in all three cases, mutual friends of ours who personally knew those families said it was obvious that the parents and siblings had Asperger's, not social anxiety. Um, yeah, so my, yeah, I can just, I think my mother and brother are both odd in some ways. My mother clearly has some ADHD symptoms, clearly has some OCD symptoms. um, whether there's something else going on as well. My brother does not seem to have any ADHD symptoms I'm aware of, and maybe OCPD more than OCD symptoms. Um, but yes, well, there's other more convoluted things. I think, particularly in today's broader spectrum, there are many people who, upon interacting with my brother, would conclude he is on that spectrum. That's what I will say. And he's has a doctorate, and has been successful in some ways in his career. Flowers ask, attention seeking, what's it look like in shrink patients? Um, I mean, one, since I don't get to like, so that was sound connection. So I think in general that usually therapy is a microcosm of the greater world. So I think people who are attention. So what's it look like in a therapy session? Um, I mean, therapy should be all about you. So it's not someone bringing attention to themselves. It's how, when describing anecdotes of how they've interacted, it may be less awareness of how other people might have seen them, or if they're describing that, then it's all how everyone was applauding and joyously celebrating whatever this person did. I'm not Maybe I'm not understanding the question, or I need to think about it more. So Max, thanks for providing the link to the video on acidity and ADHD medications. Um, and thanks that, I guess this sounds been going in and out, the connections in and out. But I guess it's working now. Good. So is cringing a term that's used in a medical setting? I mean, one is, it wasn't that it wasn't used nearly as pervasively 20 years ago in a non-medical setting as it is now. Could it be interpreted as feelings of shame or guilt when directed at oneself? Yeah, I mean, I think cringe is usually used when we interpret that someone's doing something that is embarrassing themselves. And I think often that implies or involves some projection that if we were that person, or we were in that situation, we would be embarrassed or feel guilty because of it. Um, I'm not quite sure if I'm going in any useful direction with that, so you can redirect me. So, how do patients attention seek during appointments? I'm not. I'm still not sure that I'm. So, with again, I would say the pers. I mean, the purpose of an appointment should be centered around the person. So, in that level, any attention seeking is appropriate. I mean, and particularly someone might need to be encouraged to share what they're thinking or really think or feeling, rather than hiding it or covering it up. Um, yeah, I'm. How do so? What would be considered attention, or why would a doctor in a chart note write this person is attention seeking? And this is different. I mean, many patients seek validation, which I would consider different than attention seeking. So attention seeking, I would define as anything that's saying, look at me. Validation is more not just look at me, but see me and identify that what I'm saying or doing or feeling has some validity or worth. Um, so there are many people with anxiety issues, others who are just constantly seeking reassurance. I have a patient, I won't say too much more, who is cognitively intact, and yet and I see them weekly, and yet at least half the time between appointments, and we have a fixed appointment time, we'll call and ask for reassurance that we're really meeting at the same given time in the coming week. And sometimes we'll leave 3 messages, voicemails on the same day. So I'd say that's a form of validation seeking or reassurance seeking. Um, so, and maybe if I'm missing the question, you know, I guess there's more down below. How indirectly attention seeking or validation seeking more subtle? Um, so I'm seeing more James Alexander questions. Do you think the elevated state of executive function that amphetamine medications provide to people without ADHD is the same as the natural state of naturally high executive function people? For example, do naturally high executive functioning people just go through their day with a similar level of elevated confidence and mood that amphetamine medications induce in everyone else? So, no, I mean, so that's maybe I might be missing part of the question, but I do think enhancement of executive functions is not necessarily correlated with mood or self confidence. Um, There's some people who are extremely focused, direct, linear, able to process information quickly, able to inhibit their responses. And even if, some of them do have high opinions of themselves, and some of them still, probably because of constellation of childhood and other maybe genetic temperamental factors, even despite, I mean, part of this is I do have a talk on imposter syndrome. Even though they've demonstrated competence, don't feel confident. And so, so I would put confidence in a separate domain than executive functioning competence, and I would put mood is separate but interacting with confidence. So you can be sad or prone to negativity again, despite confidence. And yes, so amphetamines do tend to boost all of those in people with ADHD or without. But I think that's maybe one, but I don't, yeah, I don't know if I said so. I think stimulants tend to boost energy level, they tend to boost confidence, they tend to boost mood, they tend to boost executive functioning, all of those. But I think those are all separable and there are different factors that could, I mean, you can target mood without targeting the other 4 things I just mentioned there. So, yes. So, Flowers is asking again on the validation or attention seeking. I mean, I can remember, and I haven't worked with a lot of people who clearly, robustly meet histrionic personality disorder, but I can think of 1 or 2, and both that I'm thinking of right now are women who, were wore excessive amounts of perfume or excessively showy, revealing, ostentatious wardrobe choices or hair piled up, 2 feet on top of their head with different types of accoutrements skewered through their hair. So again, I think those were part of what they were doing when they're out in the world in general. I mean, it might have been that they were amped it up or did it more so, or maybe less so when they came to see me. I don't know. Max asks, at what point do you feel comfortable establishing a firm diagnosis with a patient? Right at the start, or do you say that you suspect a condition and will see with treatment if you can confirm it? Um, yeah, I'm going to give a non-answer answer, and that each case or each individual is different. I mean, there's some people who come in presenting with classic symptoms and a review of a differential diagnosis or other alternatives doesn't turn up anything that's likely contributory and it's fairly straightforward, or they already come in with the diagnosis for years that fits and has been well treated in the past. So those people, it's pretty easy to immediately come up with a diagnosis. I would say diagnosis is always a working diagnosis and subjective to change, but that's a theoretical stance. And in practice, I think for most people, most of the time, most doctors are deciding, yes, this is mostly ADHD, or this is depression and ADHD, or this is bipolar and not ADHD, and operating from there. But I think part of the scientific method or approach requires maintaining an open mind and new data. And if it doesn't conform, or so the a different take on some of your question is that I've certainly had people who I've suggested that ADHD could be part of their diagnosis or part of what's going on. And in two different types of scenarios, one where they were just completely unfamiliar with it or what it really meant and therefore rejected it, or that they had been previously diagnosed with it and didn't feel that. So that's a very different scenario, had specific rejection of it or didn't feel that that treatment worked, or they had been stigmatized because of it. So with those people, in my head, I may be very comfortable with this is ADHD or ADHD is a part of it, but getting them to be aware of it or see it is a process. And I think in an earlier stage in my career, I think it was important for me to have patients always aligned on our diagnostic agreement. And I guess I'm less fundamentally wedded that we have to have the same opinion. Now, if I think they don't have ADHD and they think they do, I think it would be inappropriate for me to prescribe medication that would be treating that, or even psychotherapy that was treating that. Um, but whether the patient and I have consensus, I think ideally we would, but I don't think we always do. So, or do we even need to? Yeah. So usually, I'd say the other scenario where I may delay, let's just say, confronting someone about a condition is with some of the personality disorders, like borderline or narcissistic personality disorder, or maybe even OCPD, obsessive compulsive, where my approach would be, and often they'd be coming in with depression or something simple first. I might say that I think there are forces or factors in addition to this. And then we would slowly unpack what those other forces or factors. And I think it's really important to do identify it, because if your dysphoria, if your negative mood sensations are coming primarily from borderline personality disorder, and you're believing that it's depression and the right antidepressant's going to cure it all, that's a setup for disappointment and lack of success. So acknowledging these other conditions when they may be there, I think in the long run is helpful and powerfully helpful, but it can be more than someone is ready for initially. Um, Flowers asks us our trauma industry opinion. I'll share an interesting take on that. I see it there that there are numerous therapists who focus on everything is trauma, and literally they will say that, and that everyone's traumatized, and more specifically, there's people who don't believe in the existence of ADHD or exist or believe that ADHD is only the result of trauma. And are these people making money off of that? Is there a network that's self-reinforcing? That I would say is, to me, the definition of an industry. And in the book I'm writing about ADHD and ADHD world, I used that phrase when discussing the overlap. And the publishers I'm working with are a mental health publishing company. And I got lots of pushback against that term. So I dropped it. I can describe what I'm explaining without. So the term is, I would agree, somewhat pejorative. Um, is there way too much trauma in the world? Some trauma I would argue is inevitable since accidents I don't think are completely preventable. And, you know, a meteorite goes through your ceiling and kills your mom in front of your face, you're going to be traumatized. Well, you might be traumatized, but you have a likelihood of being traumatized by that. Um, so I think we can't eliminate all trauma, but there's a lot of what I would label excess trauma caused by humans, stupidity, greed, malice, and other factors. So, is it good that we are pushing back against that? Is it good that we're helping people work through that? Is that potentially a disruptive trauma, highly disruptive factor in people's lives and brains? Yes. So, so James Alexander is asking follow up on the fish oil question. So, we may shop in different places. I don't hang out at health food stores much, but places like CVS, Walgreens, Trader Joe's, and Costco, maybe these days where I shop. No Trader Joe's on the Big Island of Hawaii, though. Um, Most of the fish oil supplements still that I see are a 2-to-1 ratio of EPA to DHA. So that's what's routinely most available or most prevalent. Whether a different ratio is more optimal, again, particularly in terms of the helping the brain, maybe more DHA, but maybe in terms of affecting lipids, other lipids, cholesterol, triglycerides. It depends what we're targeting there. Um, but since it's readily available, I would stick with the 2-to-1. That's what I see in the stores. Um, and I'm not so OTP, and that's the last. It's a non-question because I'm not familiar just with the acronym ARFID. So I'll get back to when I figure out what RFID is and whether there's any link to Hypersmell. So thanks for being here. Thanks for listening. Thanks for asking good questions. And thanks for sharing this channel with other people who might be interested in ADHD. I'll be back next week, same time. Thanks. And hopefully we'll have an adequate connection.